Hello, everyone. Welcome to the Virtual ALS Patient Caregiver Information Forum. My name is Sophia Brown from Ogilvy Health, and I will be moderating this forum on behalf of the ALS Canadian Alliance. The ALS Canadian Alliance collectively strives to enhance the quality of life for all people living with and affected by ALS and supporting research to find the cause and cure. They do this by building partnerships, working collaboratively, uniting to connect Canadians living with ALS, advocating for people living with ALS, and building capacity. The founding members of the ALS Canadian Alliance are Executive Director Wendy Toyer from ALS Society of British Columbia. Welcome, Wendy. Executive Director Leslie Rink Adams from ALS Society of Alberta. Executive Director Dennis Simmerd from ALS Society of Saskatchewan. And Executive Director Diana Rasmussen, ALS Society of Manitoba. President Lana Mill from ALS Society of PEI. And finally, CEO and President Kimberly Carter from ALS Society of New Brunswick and Nova Scotia. So who is here today? It looks like we have a majority of people here from British Columbia and Alberta, and as well as across Canada from Manitoba to PEI, which is really great to see. And the majority of people here today are either caregivers or people living with ALS. So welcome, everyone. It is certainly a great turnout. So to introduce our speakers, today we have Dr. Sultan Darvesh, who's a professor and staff neurologist in the Department of Medicine at Queen Elizabeth II Health Science Centre in Halifax, Canada. We have Dr. Wendy Johnston, professor of medicine and neurology at the University of Alberta. Dr. Elizabeth Bannerman, registered psychologist. She's also founder of the ALS Society of BC Psychological Support Program and assisted Nova Scotia in starting a similar program there. And finally, we have Katie Henley, who's a research project coordinator from the University of Calgary Clinical Neurosciences. So we have put together a great agenda for everyone today. Each presentation will be approximately 20 minutes long. We're aiming for a 2-hour webinar. Just a note for the Q&A, we will be taking all of your questions at the end of the webinar. We've allotted 30 minutes for this, and we will try to get to all questions if we can. If you have any personal health questions, concerns, or questions about specific therapeutics, we kindly ask you to discuss this directly with your healthcare professional. And I'll hand this over to Craig St. Armor from Amylyx.
Thank you, Sophia, and thank you for having us today. And this session is sponsored by Amylyx Canada. Amylyx wants to do more for people living with neurodegenerative diseases and their families. We want to partner with individuals and organizations who share our passion for bringing innovative ideas and solutions to the unmet needs of the ALS community. And working together, we can leverage our strengths, resources, and relationships to make an impact on the lives of those who need it. Thank you.
Thank you. Thank you, Craig. So before we get started, just wanted to go through quick housekeeping. Like I mentioned, the Q&A will be towards the end of the webinar. So at the bottom of your screen, you should see the Q&A button to submit your questions. And if you feel comfortable, you can also raise your hand if you wish to ask a question verbally. And this webinar will be recorded and available to you all after the webinar, and a link will be provided by email, which will direct you to the recording. And to request for technical support, please use the chat box, which you can also see at the bottom of your screen. So without further ado, I would like to invite Dr. Darvesh to begin his presentation. We'll just give him a moment.
Can you hear me now?
Yes.
You can see my slides.
Not yet.
You can't see my slides?
Not yet.
Oh. Screen.
Would you like me to present them for you?
Yeah, it may be, you can't see, I can see them on my screen, but if you can't see them, then maybe you can start that.
Okay. Not a problem.
And will you be controlling the movement of the slides?
I will, so just let me know and
Yeah.
I can click to the next slide.
Okay, you let me know when everything is ready.
Perfect. All right.
Okay. So thank you very much. I'd like to thank the organizers for inviting me to present today. As you know, I'm a cognitive neurologist. I see patients with cognitive and behavioral issues, and I've been asked to talk about frontotemporal dementia in general and some aspects related to frontotemporal dementia and ALS. So can you have the first slide then? It says outline. So I will be discussing the occurrence of frontotemporal dementia in ALS and the occurrence of ALS in frontotemporal dementia. So most of the patients that I would see would be coming in with frontotemporal dementia, but occasionally I see patients who are sent to me through ALS clinic with some question about whether this is FTD or not. And we'll talk about clinical presentations, and that's what I've been asked to do. And in clinical presentations, we will be discussing cognitive impairment or behavioral impairment without dementia and with dementia. Because the distinction there is that there may be issues with behavior or cognition which does not interfere with daily living related to cognition or behavior. That would be cognitive impairment or behavioral impairment. Otherwise, if it interferes with activities of daily living, then that would be dementia, and we'll talk about that. So these are the slides. This is a slide with some of the papers because we follow some of the guidelines that people develop, and so I will share with you my experience, but also guidelines with respect to ALS and frontotemporal spectrum disorder, and with respect to frontotemporal dementia. So when you look at the people with motor neuron disease in general, 75% of people will have behavioral disturbance, will have some subtle changes, which may or may not be of relevance to them or their caregivers, but you'll find some changes which may or may not be related to the motor dysfunction. About a quarter of individuals will have executive dysfunction, and we will talk about what that means, but will have no dementia. I said if that does not interfere with activities, then there will be no dementia. And about 10 to 15% of persons with motor neuron disease will meet the criteria for frontotemporal dementia. Now, when we talk about frontotemporal dementia, that's a specific condition, but there are some individuals who may have motor neuron disease or ALS who may have other conditions that affect their cognition. So conversely, when you look at people who present with frontotemporal dementia, then they may have subtle changes in their motor system. And about 15% of people with frontotemporal dementia may develop motor neuron disease. So those are the approximate numbers that people have in the literature. So now let's talk about ALS with cognitive impairment. What are cognitive functions? Cognitive functions are these four: executive function, and we'll talk about that, language function, and this is independent of inability to talk, with slurred speech, because there may be tongue weakness or facial weakness. This is not that. Language is where there is an issue with higher cognitive effect. That is to say, inability to understand language, inability to express oneself, one's thoughts. That's what we mean. And then there is memory issues, and visual spatial function, where people, that's one's ability to interpret the visual information, what we see. You know, this is a road that I've been before. This is a tree I've seen many times. This is the door to the bathroom, etc. And so these are the cognitive function. When we talk about executive function, what is executive function? Executive function is a situation where one has to integrate all the information that is coming to them, so that one may be able to execute complex tasks. So that requires initiation of a task. It requires motivation. It requires one to be able to form a strategy to do something. It requires an individual to set from one thing to another. Otherwise, one keeps on doing the same thing over and over again. There is issue of sustained attention. And then there is the inhibition of attention. There are some things you don't want to be distracting you, so you inhibit that. That's part of the executive function. There is the sequencing. You do this thing first, and then this one, and the next one, etc. So those are executive function. Organization of one's tasks. Abstraction. We talk in an abstract sense all the time, and we don't even think about it, right? But when people have difficulties with executive function, they may have difficulty interpreting what they are hearing. So, for example, you know, it's not uncommon for people to say, okay, I'm just going to go hop in the shower. Well, you know, that is an abstract thought, right? And that could be construed differently if one is not able to abstract. And of course, there's decision-making process. Some people include social cognition with executive function. Social cognition is where we store information, we process information, and we apply that information about ourselves and about others. And that comes issues about empathy and emotional processing and all that. So executive function, social cognition can go together sometimes. So when we have ALS with cognitive impairment, so we talked about executive function. Now let's talk about language function. So there are some people may have difficulties with language, difficulties with naming, difficulties with nouns. And this is another important one, action verbs. You know, if somebody has difficulties with language function and they do not understand action verbs, then it becomes quite difficult. You know, they may not be able to interpret when we say eat something or drink something or try something. If they're not able to interpret those action verbs, it could be difficult. And then there is object knowledge, sentence processing, grammars, and paraphasias are things where we try to say one thing and it comes out differently. So we stumble on words sometimes. You know, we try to say table and clable comes out. But when one individual makes a lot of these, they are called paraphasic errors. Memory, it's very rare for memory to occur in isolation in patients with FTD. It can occur. But when you look at a lot of people who say that they've got a problem with memory, there is no specific pattern that people have been able to recognize, because in memory, there are several stages. It's a complex issue, but at the simplest level, it is you register information, you encode it, you store it in your brain, and then you retrieve it later on. And so there's no clear pattern of where the memory difficulties are in FTD, but in frontotemporal dementia, but it is not common for it to occur in isolation. So when we look at these signs and these symptoms, an individual may not have all of these signs or symptoms. So there are some criteria, the guidelines of when to make a diagnosis of ALS with cognitive impairment. So there may be difficulties with verbal fluency, for example, which is a test of executive function, and there may be other combinations that allows one to make a diagnosis of ALS with cognitive impairment. What about behavioral impairment? 70% of individuals with behavioral impairment may have apathy. Apathy is you not wanting to do things, not interested in doing things. And sometimes it's very difficult to distinguish apathy from depression. And that requires a very careful assessment. But about 70% will have difficulties with apathy. There is disinhibition, doing things that are inappropriate. Loss of empathy, right? This is social cognition. Loss of empathy. And there may be some aggressive behavior sometimes, agitation, there may be delusions, and sometimes hallucinations. And once again, I put social cognition here in emotional processing because that could be part of behavioral disturbance. And so when there is a problem, when we in any of these behavioral, then we need certain guidelines to be able to make a diagnosis of ALS with behavioral impairment. Sometimes people may have both behavioral changes and cognitive changes. So that would be ALS with behavioral and cognitive impairment. So now let's look at dementia. We talked about cognitive impairment. These are impairments or behavioral impairment that does not impact function. But here it impacts function. And that's what the definition of dementia is. That is an acquired problem with difficulties with cognition or behavior that interfere with one's ability to function. And here, it would be the difficulties that interfere not with motor system, but cognitive and behavioral system. And here there are specific guidelines. So when we look at ALS with frontotemporal spectrum disorders, there are many disorders or conditions that we can see. And the first one there I've listed is lobar degeneration, the frontotemporal lobar degeneration. The other ones we talked about. So let's see what frontotemporal lobar degeneration is. This encompasses several conditions that are distinct. One is behavioral variant of frontotemporal dementia. The second one is semantic dementia. Semantic dementia is where people have difficulties with semantic knowledge, meaning of words, meaning of things in the world. And the primary progressive aphasia would be part of the language disturbance. And these are put together in an umbrella term, frontotemporal lobar degeneration. So when we look at behavioral variant of frontotemporal dementia, we are talking about a disorder of social conduct. What does that mean? This is once again, a behavior variant is a progressive deterioration of behavior or cognition, which we observe, or we get it from history, from caregivers or people who know the person. So it is a social conduct, behavioral disinhibition, where people may start doing inappropriate things socially. There may be loss of manners and decorum. There may be impulsivity and careless actions. And once again, we see apathy and inertia, which is part of the behavioral variant of FTD. The other one is loss of sympathy and empathy. We hear that quite a bit. That they don't have any concern for other people's feelings. There may be loss of interest in social activities or personal warmth. There are times, because the front part of the brain is affected, that people will do repetitive behavior. Sometimes we do something and we stop, right? There's inhibition of one's act. But there may be times when somebody may do repetitive behavior and movements, or there may be compulsive behaviors or stereotype speech. They may say the same thing over and over again, which we have seen before. And the other thing is dietary changes. You'll see people may have altered food preferences. Usually people will start eating more chocolate or sweet things, for example, or there's binge eating and such. So there's change in dietary habits can be part of this condition. And once again, I mentioned before about language disturbance. Part of the frontotemporal dementia can be language disturbance, which is either progressive non-fluent aphasia where somebody has difficulty expressing themselves, or semantic dementia that I mentioned earlier on. And so when one makes a diagnosis of ALS with FTD, you need to have the presence of behavioral or cognitive impairment that follow several guidelines in order for one to make a diagnosis of ALS and FTD. And so, as I mentioned earlier on, FTD is not the only condition that can affect individuals with ALS. There are other things that can take place, and that's why people may send the patient to my clinic to see if there is something else. Is this FTD with ALS, or could it be some other form of dementia that requires investigation? And so what we have gone through are the numbers in occurrence of frontotemporal dementia in persons with ALS, in occurrence of ALS who present with frontotemporal dementia. And we talked about clinical presentations. Here we have clinical presentations where there is ALS with cognitive impairment, ALS with behavioral impairment, or ALS with FTD. And so those are the things that I wanted to share with you. And there is obviously the need to continue to do research in this condition, in these conditions, in order to see what are the causes of this, so we can manage these conditions better. So thank you very much for inviting me, and we'll talk later on with some questions.
Thank you so much, Dr. Darvesh, for that presentation. Next up, we have Katie Henley.
All right, good morning, everyone, or good afternoon for some. It's still morning for me. Can everyone hear me okay? Wonderful. So my name is Katie Henley, and I am a project coordinator with the Canadian Neuromuscular Disease Registry, and I'm here to introduce you to the CNDR. I want to thank the Canadian ALS Alliance for organizing this, and for AMLX for sponsoring, and for everyone for inviting me to speak. Now, as many of you know, ALS falls within the rare disease category, and there are many challenges for rare diseases. This includes a limited understanding of where patients are in Canada, varying quality and consistency of care across Canada, a lengthy time to diagnosis, as I'm sure many of you have experienced, and the quality of life data and understanding patient quality of life is quite limited. There are challenges in understanding the patient voice and advocacy, and there are challenges in patients getting access to treatment. In CNDR, we want to use our research to confront these rare disease challenges. We want to use our research projects using the patient data in the registry to provide the ability to characterize the Canadian population with ALS, improve quality of care, including time to diagnosis, understand variations in disease management across Canada, and gain insight into the quality of life of the patients, their families, and their caregivers. Now, the CNDR, what are we? I'm sure some of you have heard of us, some of you might even be participating already, and some of you might have no clue what I'm talking about. So we are a registry that spans across Canada that collects information on patients with neuromuscular diseases. So a registry is a collection of standardized information about a group of individuals, such as those living with the same disease, that is used for a variety of specific purposes. In our specific case, we're basically a database of information, and we collect patient medical information all across the country, and we try to use it for as much research as we can. Now, the Canadian Neuromuscular Disease Registry, or as I'm sure you've heard me say CNDR, because the full Canadian Neuromuscular can be a mouthful. We facilitate research that benefits patients, families, and caregivers, and promotes the development of effective therapies for neuromuscular diseases. Now, Where are we? Who are we? We are a multi-center national collaborative program. What that means is we work with different research institutions across the country and different ALS clinics across the country to consent patients and have patients participate in our research. While we are across Canada and a national program, our central office is based out of the University of Calgary in Calgary, Alberta. Some of you may be seeing some familiar faces on here, maybe some of our Calgary patients, but for many of you, this is who is behind the back end of the CNDR. Now, how it works. We want to bring together the whole ALS community, and our number one goal is to make sure our research is aligned with the values of the ALS community. We work with scientists, regulatory bodies in government, industry partners, clinicians, healthcare professionals, and patient organizations like the ALS Society to make sure that our research aligns with the goals of the community. Our research is guided by specific objectives. It's overseen by governance processes. It's adaptable and responsive, and we take proper stewardship of our data. Now, what this means is we take care in that our data and your medical information is safe, secure, and used for proper research. We take a lot of care in the research that we do. Now, how does it work? Patients can register to share their data. Their data is their medical information that we look at. Then their physicians provide this medical information into the registry, and we at the national office use that information for as many different projects as we possibly can. As well, there is an opportunity that patients may be contacted for additional research studies. That is something when you consent, if there are clinical trials or other research projects going on and you're eligible, we can reach out to patients and inform them that they have that opportunity. Now, this fun little map over here, you can see some colors. The red areas represent our most dense patients, with yellow and orange being least dense, but it represents our patients in Canada. We have over 6,000 patients registered in the CNDR. Over 2,000 of those are ALS patients, which is super awesome. Now, how we use your information. As of 2022, we had participated in over 200 research projects. Now, obviously, 2023 is not over yet, so I don't have the final number for that, but I can say we have well over 250 research projects now. These projects include clinical trial feasibility and planning, advocacy within government and hospitals, different research-specific projects like monitoring disease progression, how many patients and where they are with the specific disease, and safety and effectiveness of new therapies. We also do a lot of surveys and questionnaires for patients, families, caregivers, and we send out informational pieces. So if any patient organizations, for example, need to contact a large group of neuromuscular disease patients, we can help facilitate that. So these are some examples of where the medical information goes and what we use it for. Now, these are some examples of ALS-specific studies that we've done. As we know, ALS is a large population in our CNDR with over 2,000 patients of our 6,000. We've looked at time to diagnosis and the differences in how it takes to diagnose in different provinces and the differences of care. We've looked at the average drive time to clinic, understanding the burden of attending clinic. We have looked at feeding tube use and ventilation use in patients in Canada to see how the disease is affecting them, the disease progression, and their quality of life. We are also working on projects with edaravone and Albrioza. I'm sure you have heard those names before, to look at the safety and tolerability and effectiveness of their drugs. Now, these are some examples of some projects that we have done that work with patients and where we've connected directly with patients. We like to get an idea from the patients of what they want to see in research and what is important to them versus what is not important. Now, one big survey that we did that exemplifies this is we did a patient engagement survey where we sent out a questionnaire to our patients all across Canada to try and understand what motivates them to do research and what kind of research they want to see and what they feel is important in research versus not important. And now the exciting part is the results from those surveys. I'm sure you all are interested to hear. It was found that the most important points that patients care about in research is researching medications, treatments, and therapies, understanding patient independence in daily activities, mobility and motor function, patient fatigue and energy levels, and understanding the access to supports and services. We had around 300 responses for this survey, and about 40 of those were ALS. So again, a nice show of the ALS patients in this. We also found that the motivations for participating in the CNDR registry included to improve their own patient care, to participate in clinical trials, to contribute to the knowledge and understanding of the disease, a desire to help others and to further the disease research, and to participate in other research. Now, if this sounds interesting to any of you, I'm sure you're wondering how you can participate. You can ask your neuromuscular physician at clinic about it the next time you see them, or if you have any questions or concerns, you can contact the CNDR National Office. Our website is just cndr.org, and it'll give you all the information and a way to contact, or that is our main email. If you are interested in this, you'll be given the opportunity to read a consent form, and that explains what's required of you, how the registry works, and it goes more into depth as to what we use your information for. And then you can contact our national office or your physician if you have any questions about the consent. And if you agree with the consent, you can sign it and sign up to have your medical information shared and participate with our registry. Now, of course, participation in the registry is not mandatory. It will not affect your clinical care, and no one here is required to do anything. I'm just giving some options today. Now, if you're interested in specifically registering, not finding any more information, or finding more information, you can ask your doctor at your next clinic visit, or if you go online to our website, it has a part where you can register online right for us. So you can also scan the QR code on the screen right now, and it'll pull you right to our website if you scan it on your phone or a tablet. I just want to quickly mention the funders that we have. These are historic and current funders, as well as the government and patient organization partners that we currently work with. And if anyone has any questions at all, you can contact me directly. My email is on the screen. I'm happy to tell you more about the registry, help you consent. If you're not sure if you've registered in the past and you want to find out, or if you just have any questions about the research that we do in general, I would be happy to hear from any and all of you. Thank you so much to everyone for your time today.
Thank you, Katie, so much for your presentation. Next up, I believe we have Dr. Bannerman.
Okay, I'll try to share my screen here. Hopefully not run into too many problems doing that. There we go. Does everybody see that?
That's perfect. Thank you.
Perfect. Okay, what I want to talk about today, I'm pleased to be here and pretty honored to be invited today to speak about this. What I see is what's dear to my heart, because I've been involved with ALS both personally and professionally, having a friend and a family member both pass away through ALS, and then working with this to develop the psychological treatment program for ALS BC. So what I want to talk to about is what I entitle Bend Not Break. So how do you cope with the stress, all of the losses and the myriad of emotions associated with ALS? So as you'll notice, my slides are very personal. This is a tree right outside of my home, and I call it my ALS tree. His name's Sid because it's a cedrus tree. And if you notice the trunk of this tree, it's very bendy. And I think that that is a very good metaphor for what's needed when you're coping with ALS. You need to be able to be very resilient, to be able to be flexible, to be able to bend, and that facilitates coping. So now I'm just gonna see if I can move this away because I can't see my slides. Okay. The need to respond to the continuing changes faced by individuals with living with ALS is really challenging. And managing stress is essential for that because it enhances your overall quality of life, your emotional well-being, and decision-making abilities. When we're very stressed and it's not managed well, we don't make decisions very well. And there are so many decisions required in the ALS journey. So, and that management of stress with ALS is an ongoing process, and there's no one-size-fits-all solution. So I'm going to be providing some strategies, some suggestions, but the needs, your emotional needs, your coping strategies are likely going to change over time, and you need to be open to adapting and seeking support as necessary. So the first thing I want to mention is that you're resilient. Okay, and this is really important, and it's important that you really buy into that and believe that, because if you don't, your ability to cope, it's sort of like a self-fulfilling prophecy. If you don't believe you can cope, you won't. So what is the evidence for this statement is what you need to ask yourself. Look at your life history for evidence of your strength. Although it's nice when others remind you of your capabilities, it's more important that you prove it to yourself, because having that sense of self-efficacy is important in maintaining your resiliency. The I can. Okay. So an example of an exercise that might be helpful to complete is what I call I have, I am, I can, because doing this can help you prove to yourself that you are resilient. So examples. I have one or more persons I can trust and who love me without reservation. I have those who care about my personal needs and health. I have access to a team of knowledgeable medical professionals who will answer questions I may have. I have a belief that, whatever that belief is, that provides me with meaning and solace. I am special to my family and others. I'm a person who respects myself and other people. I'm empathetic and caring. I'm determined, committed, and strong. I can solve problems for myself, yet I can count on my loved ones and health professionals to help me out if I need it. I can generate new ways to do things. I can reach out for help when I need it. I can express thoughts and feelings in communication with others. I can manage my behavior, my feelings, and my impulses. So those are some examples of how you might fill that out. Now, so as I was saying, it's important to acknowledge your resilience, and then what can you do to build it? Make it even stronger. How do you remain resilient in the face of repeated stressors? So here's a few suggestions, but I know that you may have so many more that you can add to this list. So the one that I'm sure you hear about from so many people is, take care of yourself first. So ALS takes a lot of energy, and you have to remember the cup. You can't pour from an empty cup. So you need to put gas in the engine. Okay, and that's so important, and it's something we often don't do. So how do you fill that cup? So here are some obvious things that we often don't do, even though they're obvious. So nutrition is important. So make healthy food choices overall and eat regular meals. Exercise if you can. Just even a small amount does wonders to help relieve stress. So things like adaptive yoga and Tai Chi can be helpful for individuals with limited mobility. And those practices focus on gentle movements, breathing, relaxation, and they promote both physical and mental well-being. A good night's sleep is vital. If breathing difficulties are an issue for you, talk to your healthcare provider about solutions such as non-invasive ventilation. Take time for yourself. Pamper yourself. Engage in some pleasurable activities even when you don't really feel like it. And that's key. Do it anyway. Often we see sort of the pleasurable stuff as the fluff, the not needed stuff, and it is essential in terms of our well-being. Other important strategies to manage stress that are sometimes less obvious, do what you can. So prioritize and give up the expectation that you can do everything. Utilize your social support network, ask for help, and confide in others. Seek support from other caregivers and ALS patients. You gain strength from knowing you're not alone. Learn about ALS and how to be a caregiver. Knowledge is empowering, and it can also help you make informed decisions. It'll also help you talk with your medical professional and ask the questions that you really need to ask. Work with your healthcare team to manage specific symptoms such as pain and muscle cramps and excessive saliva production and respiratory difficulties. Express yourself. This is very important, and the way you do it is going to be very individualistic. But you can keep a journal, you can write poetry, or create art as a way to express your thoughts and emotions. Creative expression can be very therapeutic. Simplify your environment. ALS can make daily challenges much more challenging, so consider making modifications to your home environment to make it more accessible. That can reduce frustration and stress related to mobility issues. Explore technologies, and assistive devices, mobility aids. Those can enhance your quality of life. Things like power wheelchairs or eye tracking devices or voice-activated smart home systems. And when I've worked with ALS patients, one of the common themes that I've noticed is that people resist these devices, these aids, as long as they can, because of course to them it symbolizes deterioration, decline. But inevitably, when they actually get, for example, a power wheelchair, they often say to me, in fact, almost all of the time say to me, why didn't I do this earlier? It would have made life so much better, and I would have had so much more energy to put towards other things. And so I'm telling you this because of my learning from ALS patients and caregivers. Engage in activities that nurture your emotional and spiritual health. This may include, the practice of mindfulness, other types of meditation, relaxation techniques, connecting with your faith, or spending time in nature. Take in the good. This will help fill the cup for sure, okay? So that you have more to offer. Focus on what you can still do rather than what you can't. Celebrate achievements, no matter how small they may seem. And explore your motivation for continuing to struggle with this disease and caregiving, and remind yourself of it. Now again, picture from my own home. This is Gui Yin. If I pronounce it incorrectly, sorry. But this is the goddess of compassion in Buddhist theoretical tradition. And of course, as a psychologist, I'm not a Buddhist, but I like the emphasis on compassion, because self-compassion is crucial, okay? Instead of being critical of your performance, any dips you may have in your mood or negative thoughts that come up, can you acknowledge that you're human? You're trying your very best in the face of incredible challenges and adversity, and be kind to yourself. Loving kindness or metta meditation can be helpful to cultivate that. And there are many examples on YouTube of varying lengths that you can seek out. I'm not providing any specific examples because it's very individual what you would like. And I would suggest that if people are interested in this strategy, going on YouTube and finding a variety of them, because the moderator that's doing the meditation, the guided meditation, the music in the background, all of these things, the wording that's used, you may like, one person might like and another person won't. So it's really important to be selective and have a variety of options. Now, I've talked about how to build your resiliency, but there are what I call resiliency rusters, okay? So what eats away at our resiliency and erodes our strength? The first one I call sapping self-criticism. So some examples: I'm such a burden, I can't even do whatever. I'm such a caregiver fail. He or she deserves so much better than me. I'm so selfish for even complaining. Now, we often get into this after we've had this external, the anger. We've had this external anger that's, blaming other people, blaming the world, blaming life, and it's not fair kind of thing. And then after that, a second stage usually becomes blaming ourselves, anger towards ourselves. Okay. And that is definitely a resiliency rester. Now, the pursuit of excellence versus impossible perfectionism. So how can you tell which you're doing? Are you pursuing being an excellent caregiver, for example, or being a perfect caregiver? So one of the things that I always ask people is, ask yourself, is it ever going to be good enough? Is anything I'm going to do make it good enough? That's impossible perfectionism. Okay. I use the analogy of, if a child comes home from school with 80% on their test, do you say, why didn't you get 100%? What's wrong with you? And that's what so many of us are doing with this perfectionistic standpoint. It is very definitely whipping ourselves. If we don't keep a check on this, depression can creep up unbidden. Okay. So what to do? How to prevent this sapping self-criticism? Okay. Congratulate yourself for even trying. It's better to have tried and failed than never to have tried at all. Go to the editing department. Ask yourself, what part of this criticism would I own? And should I own and accept? And what's unreasonable? If you're not able to do that and get clarity, run your criticism by someone you trust and ask them what they think of it. Do they think it's too much? And then encourage yourself and develop a plan of how you might improve if it is not impossible criticism. The second resiliency rester, I term the emotional megaphone. And here's what I mean by that. Okay. Have you been overlooking your emotions? Because you're afraid, because they may overwhelm me. So you put on this armor around you and you just push them down. The problem when we neglect emotions is that they scream at us until we listen. So it's like a pressure cooker builds and then it explodes. And it's also exhausting to keep on resisting and holding down that emotion. So to prevent this, just start by pick an emotion you feel, name it, welcome it, and move on. And notice your learning history. Notice if in the past, what you've learned about emotion, is it something to fear, or have you learned to welcome it? So how do you live with the emotions that you're welcoming? And in ALS, fear and anger and resentment and anticipatory grief, how do you deal with those while trying to be resilient? Some ideas are, staying busy, out of your head, basically. Mindfulness is a really fabulous practice to start developing. Basically, it's one of acceptance without judgment and staying in the present. Combines all of those three things, and check in and learn. Check in with those emotions and try to learn from them. Okay. Emotions often carry very valuable messages. So, for example, if we're anxious, that can motivate us to think critically about a situation causing stress, or develop strategies to cope with some underlying issues. It can prompt problem-solving behaviors. If we're feeling sad, maybe that's a message that we need to be kind and loving towards ourselves. It can be a signal you need emotional support or connection with others. It can prompt you to seek comfort and understanding from friends and families or other supportive individuals. It might also highlight what is truly important to you and prompt you to reevaluate your priorities and make choices that align more closely with your values. So welcome those emotions with gratitude for what they're telling you. Also ask yourself when you're checking in about your feelings, anything new? Have things changed? Sadness may be predominant, but is there anger underneath? Or the opposite? Or is there anxiety and sadness is underneath that? Just view your emotional experiences as opportunities for personal growth. The last resiliency register that I want to talk about is meaninglessness. And this, I've left it to last because I think it is essential to counter, okay? We as individuals are wired for meaning. Finding meaning in adversity is central in helping us to cope and move forward. There's been a lot of studies on what comes out of adversity or what can potentially come out of adversity. Researchers estimate that half to 2/3 of people, most of the research is on trauma, but half to 2/3 of trauma survivors experience post-traumatic growth, like a positive psychological change that they experience after a life crisis or a traumatic event. Okay, and one of the things we know is that when we can find meaning and purpose in our lives, that's one of the things that facilitates post-traumatic growth. A lot of the other things that I have been talking about, like using a social support network and acceptance without judgment and checking in on your emotions, also facilitate post-traumatic growth. Note that adversity is common. So sometimes we get stuck in the why me game, and instead of that, why wouldn't this happen to you? We don't like to think that way, but it actually can be valuable. So what do you already know about meaning from your past learning? And learning from others. You know, I've on my slide, there's 2 books here, one from Viktor Frankl that speaks about search for meaning through the Holocaust and surviving the Holocaust. He actually developed a therapeutic approach called logos therapy, and that approach, or elements of that approach, have been used in therapies that have developed to treat chronic illness and terminal illness. And so it's very valuable, what we know in terms of helping people going through this. ALS is one example, is finding meaning, searching for meaning is really, really important. And then Michael J. Fox with Parkinson's as another example, and his book illustrates doing so. And finally, I want to end by, and just keep going one day at a time, never give up. So in summary, coping with ALS is a journey that requires strength and resilience, a combination of self-reflection, radical acceptance of what you're going through, courage and social support are needed to live life to the fullest with ALS, despite the challenges. Reach out for help when needed, cherish moments with loved ones, and focus on living life to the fullest despite the challenges. I want to thank you for your time and attention. I hope there have been some tidbits in here that can be helpful for you. And if anyone has any questions beyond those that are going to be covered in the upcoming Q&A segment, I can be reached at that email address. Thank you very much.
Thank you very much, Dr. Bannerman. Up next, I believe we have Dr. Johnston. Dr. Johnston, are you there? Okay, so while we wait for Dr. Johnston to log back on, I can start taking some questions just so we can fill a little bit of this time. We do have quite a few questions coming for you, addressed to you, Katie. So perhaps we can just ask 1 or 2 questions before Dr. Johnston comes back. So the first one for you, Katie, regarding CNDR, are the 2,000 ALS patients registered alive now, or has the data been collected over time?
So some of those patients are historical patients who have been deceased. I think we started collecting ALS patients in 2015-ish, so those numbers are from then until now, including everyone.
Perfect. Thank you so much, Katie. And I think there's one here for you, Dr. Bannerman. Would DBT be an approach used with ALS?
It can be, elements of it can be. Mindfulness is actually a big component of DBT, and emotional regulation. So both of those 2 aspects of DBT therapy would be very helpful.
Great. And I think this one is for you, Katie. Where is the research data published for patients to view?
So that is a really good question. We're in the process of updating our website so we can have all of the links to the articles and posters and stuff on there. Right now, it's kind of sporadic if it's in journals or was at conferences and stuff, but we are trying to make that more patient accessible so it can be on our website. There is some on our website now, but we're hoping to have it updated with everything very soon.
Perfect. Thank you so much, Katie. I see Dr. Johnston has just joined us. We just took a few questions while we waited. So whenever you're ready, you can start sharing your screen.
Yeah, and just testing my audio.
Perfect. You sound
Is
clear.
everything good? Okay. And just go to presentation mode and go back to the top. All right. So congratulations to my fellow speakers for staying on time. And I risked disaster by trying to still run my clinic this morning. So I am here and present for you. So I was asked by the Alliance to speak on medical assistance in dying. I'd like to thank the ALS Canadian Alliance for inviting me to this inaugural Patient Caregiver Information Forum, and commend my fellow speakers on also providing important information. Dr. Bannerman and I have met in the past, and Katie and I know each other. So these are important connections that are being made. So medical assistance in dying, or MAID, is unique to Canada. It's the idea of hastening death or having medical assistance in death is not unique to Canada, but how it came about in the Canadian context is quite unique because it was sweeping national legislation after Supreme Court ruling. And the Supreme Court ruled that denial of medical assistance in dying was unconstitutional. So no other country has had such a sweeping major change in the access to medical assistance in dying, even though there are increasing numbers of jurisdictions where medically assisted death has been legalized. And the neurologic cases prompted the change in law. It was appeals to the Supreme Court on behalf of a person with ALS and a person with another neurologic condition that prompted the Supreme Court to make their ruling. There is provincial and national reporting, and what we know is that interest in MAID is disproportionately higher in neurodegenerative diseases, and I'll talk more about that later, although cancer is the most frequent reason for MAID. So when we look at where MAID fits in, it fits into discussions around death and dying. And when we typically talk about what's happening in ALS, when we see people in clinic, we don't necessarily launch into this. It's a bit of a topic that one person or the other might feel is important. And in the palliative care world, this has been the term that's been coined is the elephant in the room. So if someone is worrying about death and dying, if they're wondering about end of life, That's what we call the elephant in the room. And in this cartoon, we see that only Alan was prepared to acknowledge the elephant in the room. And I have to presume that Alan is the person under the elephant, the one being squeezed. And so in any given encounter, in any given family, there may be one person who's concerned about that. And it may not be the person with ALS. But really, people with okay, how do I, there we go. But questions about medical assistance in dying, in my experience and reported by colleagues, don't necessarily fit into the window where people are starting to be concerned about progression or end of life. So questions about MAID actually can arise right at the beginning, right in a first encounter. That has not been unusual, that people in the context of discussing ALS and its implications will bring up medical assistance in dying. And that is even more true, was even more true when it was more in the news, when it was, there was media coverage around it. So in this cartoon of projected changes in functional well-being of patients, the second line, and can I ask, can you see my arrow, Sophia? If I move my arrow around, are you seeing that?
Yes.
Good. So if we look at this trajectory, that's not an unusual trajectory for someone with a neurodegenerative disorders, such as ALS, that they have a gradual change in functional status with maybe some sudden changes prompted by maybe an intercurrent illness or a fall. And questions about MAID can arise at the time of diagnosis, at a time of functional change, or in some instances, more when people are being very challenged towards the end when they're feeling a big change in their functional abilities. In our practice, in medical practice, and I use the Alberta Health Services because I'm in Alberta, guide to communication, we talk about end-of-life planning with a number of set terms. So one is advanced care planning, and that's what you do. It's what I do as a member of the public, as a patient. It's what we say we want. And it's the process of documenting that, your wishes for healthcare and what you want your relatives and your loved ones to know about your wishes. Goals of care designation in Alberta, and there may be similarly phrased medical terms in other provinces, is a medical order. So it's what I as a doctor will do after discussing your wishes, and it is entered as an order in our charts. And it's used to describe and communicate the general aim or focus of care. So someone who wants curative care would be one designation. Someone who wants medical care but doesn't want to be resuscitated if their heart stops would be in Alberta an M designation. And those that do not wish to have a lot of medical care, who don't want to be in the hospital, who want only care at home, and are essentially preparing for their end of life, we call that comfort care. So advanced care planning conversations don't always result in determining goals of care, but they're very important building blocks because they're conversations that you have with your family and with yourself to say, what do I really want? And then it would inform you and help inform your doctor to talk about what you want from the medical system. Just to be clear, in talking about medical assistance in dying, we're not talking about refusing treatment. And so I like to use the term declining treatment because refusing kind of sounds combative, but you have a right to decline intervention. So any medical intervention that you're offered, you can, as a competent adult, so over 18, competent, no significant cognitive impairment, despite what our first lecturer said. If you're deemed to have capacity to make decisions, then you can choose not to have something done. And that's very important. And capacity is the concept of ability to understand what's being offered. So someone who has dementia may still have capacity. They may still say, yes, I do not want this done to my body. And we would respect that. So there's a right to refuse therapy. This has been enshrined in law. And a very important case was the last one, which was Nancy B. versus Hotel Dieu de Quebec, which established the right to withdraw from invasive ventilation. And this was a patient who did not have ALS, but she had a condition that left her completely paralyzed and dependent on ventilation. So she established, by challenging this through the courts, that one has the right to withdraw. So you can decline to start, and you can withdraw from medical therapies. You can withdraw from dialysis if you're someone with kidney failure. You can withdraw from long-term ventilation if you're on a ventilator for respiratory failure. So the Canadian court system had heard two major challenges on behalf of individuals who were seeking medical assistance with dying. The first was in '93. It was Sue Rodriguez, who had ALS, and she came, it went all the way to the Supreme Court of Canada, and it was a close vote, 8-9, that they didn't legalize it out of concerns about checks and balances, and that it did not offend the principles of fundamental justice. However, 20 years later, a second court case came to the Supreme Court, again via BC, and this was called Carter versus Canada. And Kay Carter had spinal stenosis, a very debilitating condition that was leading gradually to paralysis and causing her much pain. Gloria Taylor, who had ALS, joined in the suit, and it was in response to this appeal that the Supreme Court of Canada indicated that, sorry, I got, the law indicating that, so the Supreme Court indicated that it was against the Constitution to deny people the right to a medically assisted death. And in turn, this required the government to respond by decriminalizing physicians and nurse practitioners from providing medical assistance in death. And so Bill C-14 was the one that was passed in 2016, and it's a competent adult with a grievous and irremediable medical condition who's suffering intolerably or death is reasonably foreseeable. They could voluntarily request, provide consent, and with a clear period of reflection, proceed with medical assistance in dying. And the additional provision is that it has to be eligible for funded health services delivered by Canadian jurisdiction. There is no desire for medical tourism. So at that time, our college came up with a series of recommendations to explain this. And it was determined that in Alberta, you have advanced state of decline that can't be reversed, suffering unbearably, that you have a reasonably foreseeable death, but you didn't have to have a fatal or terminal condition. The confluence of conditions that made a death reasonably foreseeable was deemed to be sufficient to render a requester eligible. You may recognize that the Supreme Court didn't specify that a death had to be reasonably foreseeable, and that would be correct. And so, not surprisingly, that was challenged in court. And subsequently, Bill C-7 in 2019 removed that restriction, that reasonable foreseeability of natural death was not an eligibility criterion, and so that was struck down. It then required the new law, Bill C-7, to come into force. And it was passed, and at that time there was an extension given due to circumstances, but we now are operating under Bill C-7 in terms of eligibility. So to summarize the changes, which do have some impact on those with ALS who would be interested in medical assistance in dying, they eliminated the 10-day period of contemplation, which was quite important because that kind of forced people to be very proactive in seeking the necessary signatures and forms. Only one witness was needed for signatures, and this was partly prompted by the pandemic. And very importantly, there were two exceptions to the requirement for final consent. So previous legislation and the recommendation of the profession was that the person who was receiving medical assistance in dying had to be competent and give a final consent at the time. This led to a lot of misunderstanding about medical management of pain, And it led to a lot of concern that people who had clearly had the capacity to consent to medical assistance in dying would be potentially being denied this in the last hours and days because they weren't able to clearly provide consent. So currently, for persons whose natural death is reasonably foreseeable, you can have an advanced consent arrangement. The additional proviso is if there is a failed self-administration, which is not something that comes up very often, but someone didn't have to be aware to consent to proceed to a lethal injection if they failed in taking an oral medication for assisted death. So there's also the amendment that individuals whose natural death is not reasonably foreseeable would be able to access MAID. This really hasn't affected people with ALS to my knowledge, because I think almost everyone can say that people with ALS do have a reasonably foreseeable death. There's no time frame. The government did not oppose a time frame. In other legislators, in other jurisdictions, a 6-month time frame has been imposed on individuals who are being allowed access to lethal prescriptions. But Canada never said there was a time frame. So it's simply that a reasonable person could see that the condition of the individual applying would result in death. However, the fact that they changed the legislation to allow those who did not have a foreseeable death kind of takes away any objection an individual physician might have had to say to an ALS patient, well, I don't think that you are close. I don't think you're close enough to death for me to say that MAID would be appropriate. So it does take away that potential argument that might have been a barrier to someone with ALS pursuing MAID. These provisions are something that I, as a practitioner doing an assessment, have to be aware of as the minimum requirements for someone who doesn't have a foreseeable death, but it hasn't really come up in ALS practice, at least for me. So just to summarize, you may not have been aware, but suicide has been legal in Canada since 1972. It's in many other countries, it is not legal. It is, however, against the law to counsel or assist another individual to complete suicide. What happened when the Supreme Court struck that down is they struck that down only for medical professionals and specific medical professionals, physicians and nurse practitioners, so that it essentially decriminalized this assistance in suicide, but only for medical practitioners. So that was the job of the Supreme Court and the federal government, is decriminalizing it. But medical care is provincial. And so the provision of MAID as a medical procedure falls under provincial jurisdiction. And that leads to certainly a complication for me as a presenter, because the provincial guidance for MAID across the country varies somewhat, and there's subtle differences in each province. So it's very difficult for me to generalize in a completely confident way about how you in your individual province would be walking through the steps of finding out about medical assistance in dying and potentially accessing it. So each of these provinces has their own differences in the process, in the steps taken. So I'm not going to be going through this confusing slide in detail. It's simply to show that if you look at the individual health system websites, they all differ slightly. The majority, I think all of them, start with connect with your physician, discuss with a healthcare professional. The exception is Saskatchewan, where you can connect with the MAID team as the initial step. Many provinces allow contact the MAID team as a fallback. They recommend that you contact or discuss this with a healthcare provider. But if you don't feel comfortable, if you don't feel that there's a healthcare provider that will listen to you, these provinces will allow direct contact to the MAID team. So you can see that there are several provinces where the healthcare provider is the initial contact, and that might be a source of discomfort or a potential barrier for individuals who seek more information about medical assistance in dying. So who's interested in completing assistance in dying? And so prior to the 2015 Supreme Court ruling, there was experience and literature from many other areas. So particularly the Netherlands and Oregon in the US had a longer experience of legal assisted death. And so studies have taken place to say, well, who's really interested in this? So overwhelmingly, the evidence shows that it's not things like dissatisfaction with medical care or access to palliative care services or access to supportive services. The central aspects of this interest in assisted death relate to personal beliefs. So people who value above all independence and self-reliance, and who in themselves don't have strong spiritual beliefs. In Dutch studies in particular, they showed that fear of future suffering is actually the burden of suffering for people who express interest, not necessarily current pain and suffering. And that was true particularly of people with ALS. However, most studies were retrospective and were interviewing the caregivers, so what was reported to loved ones, not the person themselves. One study, however, did follow a group of people in Oregon who had signed up or expressed interest in and gone through the appropriate channels to access a lethal prescription and agreed to participate in the study. And it confirmed that fear of future suffering was a major motivator. It confirmed that personal characteristics predominate. That is, it's who you are, it's what you bring to how you're facing your condition. But depression and hopelessness were definitely higher in those who sought assisted death than people who had no interest in assisted death. And prior studies had also indicated that hopelessness was a major factor that distinguished people who were interested in hastened death. So when I think of the person who was in my practice when I was in Oregon, who would say to me was interested in assisted death, it was the person who was very much in control of their life, the captain of industry, the person who'd always been in charge. They were the ones who were most likely to bring it up. But there were a whole spectrum, including people who I think of would think of themselves as meek and mild. So this is, as always, generalizations, and every individual brings their own characteristics to their expressed interest. So who uses MAID? There's a lot of data because it's every year the government of Canada keeps statistics. And one of the upsides of this somewhat administratively burdensome process of applying for medical assistance in dying is we do get information from that to keep track of the process. So the most recent reporting year is 2022. It was reported in January this year. And we see in general an increase in requests, and the annual growth rate has been on average 31%. And if we have time, we can go back to the website and explore some of these issues, but I think we'll move on to the rest of the talk rather than focus in on in Canada who's using MAID. So I want to talk about what MAID is and what it isn't. So MAID provides a medically controlled death under the direct care of a medical professional, because that is how each of the colleges, each of the regulatory agencies has interpreted the law, so that it is a medical procedure, just like a hip replacement is a medical procedure, just like having a baby by cesarean section is a medical procedure. And so there are standards, and there's a possibility that someone, for example, could be sued for malpractice or be sanctioned because they didn't do it right. So it's a medical procedure under the direct care of a medical professional. Only the person receiving MAID can request it. MAID requires the involvement of at least 2 healthcare professionals, and I think this is true across Canada, that there has to be an independent assessor as well as the provider, and each of them has a multi-page form to fill out and submit to the MAID coordination service in order to get approval for continuing and proceeding with MAID. Now, currently, the MAID process can be expedited. They took out that 10-day period of reflection, but it's not an emergency procedure. So someone who develops acute suffering, who's has perhaps unanticipated suffering, they can still access MAID, but will not be immediate symptom support. So accessing MAID should not be the goal only in that situation, although that's under the direction of the person who's wanting MAID, but it should be done concurrently with expert symptom management so that people aren't suffering while they're waiting to have medical assistance and dying. MAID is not palliative care, but those receiving palliative care may request and complete MAID. So there's no headbutting. Initially, there was a lot of concern in the palliative care community, and there are many palliative care physicians who did not want to participate in MAID. But currently, people undergoing palliative care represent the majority of people who are actually accessing MAID. So per the national statistics, over 75% of those who accessed and completed MAID were receiving palliative care. The timing of MAID is personal choice, and sometimes the expressed wishes of the individual may appear to be premature, maybe to me as a doctor. It may be someone pursues MAID when they really have taken every supportive care, every decision around interventions, and then they request MAID when they've essentially satisfied themselves that these interventions are not sufficient for them to want to continue living. Symptom burden may be a reason for MAID, but the treatment of symptoms is usually provided by primary care providers. In our case, an ALS multidisciplinary clinic likely is involved, and palliative care and hospice teams can be involved. So everyone, it could be all of the above, it could be primarily palliative care, is providing support for symptom burden to decrease suffering. But accepting these services does not in any way negate your access to MAID, so that you can take full symptom support and still you would meet criteria for MAID, because suffering ultimately is defined by you, by the person who's requesting MAID. So in my practice, the majority of ALS patients actually don't complete MAID, but I'd say many patients who don't complete MAID express relief that they can access MAID. They talk about it, it's something that's acceptable morally and ethically to them, and they're reassured that it is there for them if they need it. There are patients for whom MAID is not an option due to their personal or spiritual beliefs, and that's important for us to establish as well. So I also wanted to clarify that completing a request for MAID is not the same as completing goals of care. So a request for MAID is an independent channel that goes to a MAID coordinator, to a MAID provider, and while your primary care physician or ALS doctor might have been involved at some point, maybe as the independent assessor, the request for MAID does not necessarily translate into a specific request not to be resuscitated, for example, or specifying what level of care or kind of care in the hospital is necessary. So those are really two separate conversations and in some respects decisions. So someone, for example, may be well on their way to accessing MAID in terms of being prepared, but still be fully wanting to be resuscitated, because at that time of life, their chances of a full recovery back to going home, back to their baseline are still quite good. So it's not contradictory. However, if you do plan to complete MAID and you're beginning to set a date, getting resuscitated because you didn't complete that particular goals of care designation would seem to run counter to your own wishes. So I wanted to just re-emphasize the point that MAID be expedited for acute suffering, but you shouldn't delay treatment of acute suffering, or you shouldn't fear that accepting support for acute suffering will compromise your ability to have MAID. But there are other therapies for acute suffering, which can be up to palliative sedation, which don't require an application process, that are considered standard of care. I put in this resource, dyingdignity.ca, because they have on their website all the MAID forms for all provinces and territories, so that this difference in information that I alluded to in the prior slide, the Dying with Dignity site has the information. They also have quite a few webinars, but I've not listened to these webinars, so I can't endorse them, but there is a huge resource there from an organization that feels that access to MAID is of prime importance. So how to discuss MAID with your medical provider? I think you just have to take the bull by the horns. And many times people say to me, I would like to know more about medical assistance in dying. Sometimes people kind of come into it sideways with me, and I discern that they may be wanting to talk about it. And so I can say, are you wondering about assisted death? Are you wondering about medical assistance in dying? And across Canada, physicians are required to have a response. The response may be, I'm not a provider or an assessor, but I can put you in touch with resources. It may be, let's have a full discussion about your concerns. So it's important that physicians think about, and there's been a lot of education about physicians thinking about and having a response that is a supportive response and not a close the door response. I certainly, and many physicians, feel that the questions around MAID is the first foray into discussions around advanced care planning, goals of care, or concerns about dying. And I think that that discussion can be as little or as big as you want, and it likely would take place over a number of visits over months to years. Every physician should ask about the underlying concerns about interest in medical assistance in dying, as it's often the way that people with ALS and other people with potential life-threatening diseases open the door to their fears about what end of life might look like. So every physician should have a response. You should need to know that no physician is required to be an assessor or required to be a provider. And by physician, I include nurse practitioners. And that the colleges that regulate us do require us, all providers, to at least provide the information or make an individual aware of MAID resources. So in conclusion, in my minus 30 seconds, Canadians have a right to healthcare, and MAID is considered a part of healthcare. So Canadians don't actually have a right to die, so to speak, but MAID is integral to healthcare in Canada and has become much more standard and, I think, accepted as a conversation since the original Supreme Court ruling in 2015. I do think that navigating the process can be daunting for individuals, and I suspect that that varies very much on where you live and what your medical care looks like. I think that MAID should be viewed as an end-of-life choice. It's a welcome one to many people because it gives the option of control and timing, and it should be seen as overall part of end-of-life planning. And end-of-life planning is more than requesting information applying for MAID. You should really think about it as the whole spectrum of what you want from the medical system and what your thoughts are on what could be a good death. So I will stop sharing.
Thank you so much, Dr. Johnston, for your presentation. At this point, we would like to open the floor for the Q&A portion of this webinar. A quick reminder that we will try to get to all questions if we can. And if you have any personal health questions, concerns, or questions about specific therapeutics, we kindly ask you to discuss this directly with your healthcare professional. So as a quick reminder, you can submit your question in the Q&A box down below of your screen. Or if you feel comfortable, simply you can raise your hand, which is the button next to the Q&A at the bottom of your screen. And we will try to get to all of the questions, or as many as possible. So if I can ask all the speakers to turn on their camera kindly, and we can get started. Okay, so I believe this first question is for Katie. Do patients have to pay for their information to be provided? For example, if it is their family doctor or ALS neurologist who provides the data, and are they required to pay either physicians to provide the data?
That is a really great question. No, the patients do not have to pay anything to be a part of it. I will say as well, patients don't get paid to participate in it. We request the records from your clinic, so that can be sent from the neurologist or any of the care providers there. But no, the patients don't have to pay anything.
And great. And can you speak about the similarities and differences between CNDR and Capture ALS?
I
Do you
can.
want me
I
to
don't-
take that, Katie?
Yeah, that might be great. I was just going to say, I don't think I have the right background to speak to Capture ALS.
Yeah, so I think, so I am a PI in Capture ALS, and it's a different study with the same goal of understanding ALS better. So CNDR uses clinical data that is collected in a typical clinical visit at an ALS clinic. So things like the breathing strength tests and the some of the discussion points that are had with the doctor, the ALS-FRS, many of you have done the ALS-FRS. So it's collecting data, and it's therefore sort of more widely applicable. So someone reading about the CNDR results would say, oh yeah, I can see how that applies to patients in my clinic. And you could say, oh, I think I see how that applies to maybe me. Whereas Capture is a research protocol that is doing what we call medically deep phenotyping. So we really want to understand what each of the volunteers is experiencing. They have neuroexam, they do cognitive testing, they have blood tests for many, many different blood parameters, genetic testing, they have MRIs, we've been doing ultrasound of the diaphragm. So all of this is being collected in a systematic manner to start saying, well, why are people with ALS so different? And what can we say is the same about them? So it's a prospective research trial that has a beginning and an end and is funded to do all these tests. And then we will report it and build on that knowledge. We hope to start looking at, say, individualized therapies. And if you're interested, Capture also has webinars that we can send out, and they're accessible on the Capture website. So it's all explained in great detail on over several webinars that are available to you on our website.
Great. Thank you
I
so
hope that
much.
answers the question.
Perfect. Thank you. This question is for Dr. Darvesh. Can ALS cause frontotemporal dementia?
Well, those are not causation, right? It's an association, and some of the abnormal proteins that are deposited in the brains of people with ALS can be also found in patients with FTD. So there is an overlap, and that's the whole point. And I mentioned, about 10-15% of the people with frontotemporal dementia have ALS, and vice versa. So there is that overlap.
Great.
We don't know what causes it. I just want to emphasize, we recognize a lot of things in the brains, but we do not necessarily understand it. So, when it comes to all these neurodegenerative disorders, ALS, FTD, we recognize it, but I don't think we understand the cause of it yet.
Thank you so much, Dr. Darvesh. Dr. Johnston, does MAID have an impact on life insurance?
No, it does not. Because it's medical care. It's not. So insurance in general may have restrictions on someone taking their own life in terms of paying out, but MAID is a medical procedure, and as such cannot be used to deny insurance.
And can organs be donated after MAID?
Yes. In fact, we're discussing in clinic whether we should be checking with every individual who is seeking MAID, whether that's something they want to do. We have had a number of our patients who completed MAID donate organs, and it's certainly set up here in Alberta. I know it's set up in Ontario. I suspect that this practice, because the transplant community is very standardized across the country, I suspect that you would be able to donate organs.
Perfect. Thank you so much, Dr. Johnston. Katie, a question for you. My understanding is the 2,000 ALS patients is cumulative, not current prevalent patients. My understanding is that actual amount of current percentages of ALS patients is much lower. Could you clarify?
Yeah, the number of current patients who are active and not deceased will definitely be lower. I don't have that specific number off the top of my head, just because that 2,000 number and the 6,000 total is all patients in the registry. If a patient is deceased, however, we can still use their retrospective data and look back at the information that we have on them, as long as they still provide their consent and the family hasn't said that they want to withdraw the data or anything. But when you're consented to have your research into the CNDR until you specify otherwise. So we are able to use deceased patients' information as well. So that's why we count it in those numbers. I think that answers that.
Thank you, Katie. So a question, what are the similarities in people with ALS? For example, I heard that they all have vitamin B deficiency.
Do you want me to take that? So no, they don't all have vitamin B deficiency. In fact, we routinely assess for vitamin B deficiency in ALS as part of the diagnostic workup. Many physicians will recommend taking vitamin B or B complex because it can provide a symptomatic benefit. This has been reported anecdotally. It hasn't been proven. There was a study that showed that very high dose B12 from a particular company was beneficial for people with ALS, but no one other than that first group of researchers has been able to replicate, meaning show that result again. And that was for a proprietary, meaning it was only available from a single company. And so that has not been something that has resulted in approval of a particular B12 for therapy.
Thank you, Dr. Johnston. Yeah. A similar question that came up earlier, can you donate organs only when doing MAID in a hospital?
So donation of organs has to be in a very controlled environment. So when you have a natural death at home, the organs are not sustainable in that environment. So currently, organ donation after death is potentially possible if death is observed, but you have to be resuscitated again. And that's not really possible when people have passed away naturally, because there's usually a decline of some minutes to hours where the brain and the other organs are not being fully supported by the heart and lungs. Callie has jumped in and said that in Manitoba, solid organs can be donated and tissue cannot. That is true across the country. And that is because the cause of ALS is not really known for sure. And there's the remotest possibility that if there's something contagious, and this is really a very remote concern, that tissue, for example, bone transplants could result in a long-term risk to people who don't have a life-threatening disease, whereas solid organs are basically life-saving. And so solid organs from a healthy ALS patient are felt to be ethically and medically acceptable.
Thank you. Dr. Bannerman, could you speak to depression and anxiety? Specifically, have there been any studies comparing living in the home versus living in a care facility?
I don't know of any particular studies looking at the difference between the two, and I really think that it's a very it really depends on the person. Some ALS patients will basically say, I don't want to be a burden to my family, and that's what's creating anxiety and depression for me, and I would rather be cared for by other people and be in a care facility. And other people will, you know, in terms of their own moral beliefs and values, will not feel that way. So my guess is that's going to be a very individualistic thing, but I haven't seen any research on that specifically. It's interesting that with depression and anxiety, the numbers are relatively low within ALS populations. And that's quite interesting. It's always been very interesting to me because it's, you know, as I talked about in my talk, such a stressful and such a burden for ALS patients and families. But the numbers are relatively low. They run like 30%, and that's a high estimate. So that's important to know. It proves the resilience of people, I think, and what I was talking about.
Great, thank you so much. What are some resources for learning how to become a great caregiver? So this is open to all speakers.
There are national caregiving organizations. Dr. Bannerman, do you have that reference as well?
I don't have that reference actually. I can provide it. And Sophia, when you send out the things, I can provide that. There are, you know, different provinces. I don't know how different provinces are handling that, but for the support groups are really important. And the American Psychological Association has a caregiver resource manual kind of thing that can be helpful as well.
If you're connected with a multidisciplinary clinic, you could ask the social worker for local resources.
Great, thank you, everyone. I'm just checking to see if anybody has raised their hand. Nope, so we will continue asking the questions. Please feel free to submit your questions as we go along. For Dr. Johnston, in illustration, illness trajectory, what is the red curve? What does the red curve represent?
The red curve represents just a gradual decline. For example, someone who has a condition where they don't have any setbacks. So if you had ALS and you never had pneumonia, you never fell and broke your nose, if you didn't hit the medical system. So it's just indicating a proposed trajectory. So these are all theoretical. This is not based on, you know, 1,000 patients. It's just for illustrative purposes, for comparison.
Thank you. To Katie, could you mention the provinces that regularly contribute to registry? Do they have funding to this? I'm aware some provinces contribute no ALS data.
So any patient who is diagnosed in Canada with a neuromuscular disease can consent to participate. And we kind of do two different ways of gathering the data. The clinic themselves, who, if they have a research representative there, they can enter the data. Some clinics, as we know, do not have enough staff for that and don't have the bandwidth. So we can then request charts to our national office in Calgary and we can handle the data entry. The clinics that do the data entry on their own, like Edmonton is a wonderful one, they do get funding for that. As the clinics that contribute regularly in the provinces, majority do. I would say there are a couple. It really depends on the bandwidth of the clinic. Again, because we aren't an interventional study, the number one priority of the clinic is your clinical care. So the research kind of takes a back burner to that when they want to provide the best care possible with the resources they have.
Thank you, Katie. What is pseudobulbar effect?
Dr. Darvesh, do you want to take that
Yeah,
one?
I'm happy to do. In fact, in one of my slides, I had pseudobulbar affect, and I should have left it there. Pseudobulbar affect means that the situation can be quite distressful because the patients, the individuals may suddenly cry without any feeling of sadness or laugh without feeling happy. And it can happen spontaneously. Either one of them can happen. Sometimes it's one or the other. But these are things that happen spontaneously. That's why the word pseudo. Pseudo means fake in a way, in the true sense of the word. It maybe so. It could have been another word for that. But it's an affect without the feeling that one has, right? So laughing without feeling joy, or crying without feeling sadness, is typically called pseudobulbar affect.
I also look upon exaggerated responses. So you're talking about spontaneous, but also exaggerated. So someone who like bursts into tears watching a commercial, someone who laughs, or it is inappropriate, like laughing at a funeral. So when the emotional expression is not reflecting the true emotion of the individual. And so I compare it to the hyperreflexia. So you may have experienced when the doctor taps your knee and your leg jerks out quite a bit. So that's an increased stretch reflex from the muscle. So I look upon it as an increased emotional reflex, and the increased emotional reflex can be quite embarrassing.
And is it also an inability to shut it off?
Yeah, so it doesn't come
that's
under
it.
control as easily. Yeah.
Great, thank you. Anybody else would like to comment? We can move on to the next question, which is for Dr. Darvesh again. Does FTD usually happen at the onset of ALS, or can it come on at any time during the disease?
Yeah, it can come at any time. So as I mentioned in my first two slides, you can get you can get ALS first, and then develop that later on. And some people develop FTD first and develop motor neuron disease later on. So it can happen either way.
Great, thank you. And a question for anyone. Did you want to add to that? No? Perfect. So are any of you familiar with the work of Gaber MAID regarding a possible link between ALS and PTSD? Comments?
I actually am not familiar with that, but it intrigues my interest. I would like to look at the the quality of the study about that and how many studies have been done, because I have not really read anything other than in terms of causative kinds of things, if that's what you're talking about. In terms of the trauma piece of ALS, that's completely different. If we're not looking at causation at all, and ALS is very traumatic for families as well as for patients. But again, PTSD used to be in the anxiety disorder category in the DSM. It's been taken out now as just trauma specific. But most of the research on ALS was done when it was in the anxiety disorder category. And when they talked about anxiety and ALS and the research studies that talked about those two, again, anxiety was more on the low side. And when it did present itself, it was more generalized anxiety, worrying about the future and being able to cope and those kinds of things, rather than trauma per se.
I can add to that. I get asked these questions in my clinic all the time. It could be Alzheimer's disease. It could be anything, right? Does something happen? There's always this natural thing to say, all these problems happen because this happened. I fell down the stairs or whatever it is. So causation is a totally different issue. There are sometimes the symptoms may be accentuated because of, depression or anxiety or other things, or PTSD feelings. The symptoms may be accentuated. But the cause of these disorders is not known. And that is the fundamental issue to remember. Things can be accentuated because of other circumstances, but causation is a different issue.
Thank you very much. And there's just a comment here. Gaber MAID also has a personality type associated with ALS.
I have to say that I'm not sure that Gabor Mate's research methodology is such that he could state that with evidence. So he may be speculating about that. But of course, Dr. Darvesh has talked about the neurobehavioral changes that occur in up to 75% of people with ALS. So when you talk about a certain type of person getting ALS, it might actually be that the ALS made them that certain type of person.
I think that that's probably accurate.
Thank you. And I think this next question is for Katie. How can one check if you're registered with Patient Disease Registry?
I think the best way to do that would be to honestly just send me an email with your full name, and then I can look into it for you. Maybe Sophia, in the email we send out later, we can just remind patients of my email.
Danny, you could also just ask. We could let you know.
Yeah, if you talk to anyone in your clinic, they'll have a good idea of it. If you're a patient who doesn't attend a multidisciplinary clinic, then I think sending me the info best.
Great. And has there ever been a survey or of current former ALS caregivers across Canada? Would be interesting to see responses depending on the level of accessibility to resources.
I actually think, go ahead, sorry.
No, go ahead.
I would say the ALS societies have that kind of information. And each of the societies has collected information and it's been collated. And it's not published, although I think that it's presented. Wendy, if she's on, still could comment on that. Wendy Toyer definitely is very active in that realm. So certainly about access to resources. That may be something that the ALS societies have collected information on. There hasn't been like a physician-driven or a medical system-driven caregiver survey, as far as I know.
Yes, there is the ALS handbook, and in British Columbia, that's posted on our website, and we make people aware of it when they register with us. So the handbook is developed for each province individually, because there's different resources available for government and so on in each of the different provinces. So I would get in contact with your society and ask them for the ALS handbook.
Great, thank you, Wendy. So if someone with ALS is unconscious on their last days, so to speak, can MAID be provided without the person picking a day and time of death? This is for you, Dr. Johnston.
That's a bit tricky, because if that individual has gone through the process of applying for MAID and been approved, and they've also indicated the prior consent, then they can have a designated other agree to proceed with MAID, but the person has to have set that all up in advance.
Thank you, Dr. Johnston. Just a comment, I have read a biological study identifying bacterial mycotoxins in the brain as a cause of ALS. Has anyone read about this?
There was a study a few years ago alleging that they found the RNA, the translational genetic material of certain organisms in the spinal fluid and by implication the brain. But no other lab is been able to replicate that. So in order for anything to move forward, it has to be shown that it's, not just coming from one place. The potential for contamination of materials being evaluated is very, very high with the microorganism that was described. So this is not proven to be an active area of research subsequently.
So if I may, this question about infection comes up for almost all neurodegenerative disorders. And people have found, as Dr. Johnston said, the genetic material and all that. So, we are infected with all sorts of things. Not infected, but, we are colonized by all kinds of things. And so to date, there have been no causation found between discovery of these materials in the brain and causing a neurodegenerative disorder. This has been described. People say, yes, we found this, but does it cause it? Don't know that.
So Sophia, I noticed you deleted a question about treatment of the excessive laughing and crying. There is a medication that can can help with that. In fact, there's a number of medications that we've tried, and one specifically for that symptom. So that is something that could be discussed with your neurologist.
Perfect. Thank you. I think those are all the questions. I'm just having a look. Just one comment here regarding resources for caregivers. Callie just commented that she liked the US published Your ALS guide. That was her favorite. So just something to note there as we wrap up the Q&A. Thank you everyone for your participation in the Q&A. So to wrap up this webinar, I'm just going to show my screen very quickly. So thank you everybody for your participation, and to all the speakers. Thank you so much for your contribution to this wonderful webinar. To all those who have attended, an evaluation form will be emailed to you, or if you would like, you can scan this QR code now to complete the form. So again, thank you very much. Wendy, did you have any comments that you would like to add as we wrap up?
Yes, on behalf of the ALS Canadian Alliance, I would like to thank MLX for sponsoring this. We hope to do this quarterly. So one of the questions on your survey is other topics that you would like to hear. So please let us know. Thank you to our speakers for taking the time to be part of our first session. A few glitches at the beginning, but we got those ironed out, and I really appreciate your time. And again, if you have any questions, just contact your local provincial society and they'll direct you to the right people. Thank you.